Okay. I'm going to wait just 1 or 2 more minutes here, and then we'll go ahead and get started. Sorry, guys, for the delay. We're going to go ahead and get started here. So I'll just start by introducing myself. My name's Christina. Sorry, my laptop's wiggling a little bit here. Let's see if I can get it. Zoom always has its challenges, right? So my name's Christina. I'm one of the physical therapists here at M3. I'm a little new to the team. If you've been around M3 a while, I joined here in January. I have a little 1-year-old boy at home, so he occupies a lot of my time. So I'm here a couple days a week, but I'm really excited to spend some time with you guys and get to know you a little bit and talk about the shoulder, one of my favorite regions of the body to treat. It's a very complicated joint, but I think it's interesting nonetheless. So hopefully I can answer some of your questions tonight and give you some insight maybe on what's going on with your shoulder or with someone you know. So anyways, does anyone have any questions for me off the bat or want to give me a little insight into maybe what your pain is or what you're kind of dealing with your shoulder? I think everyone's muted right now. I'll see if I can go ahead and unmute everybody here. Yes. There we go. There's the button. Okay. So does anyone have any insight to share about their shoulder or maybe what's going on with them?
Hi, I'm Caroline. I've got both shoulders that hurt. I get cortisone shots every 4 months and both shoulders, and that really does minimize the pain. I believe I have about a 25% tear in the rotator cuff.
Okay.
At least in one of them. That's what the MRI says for one of them.
Yeah.
But it's the same problem on both sides, and it impacts me with like the motion of hugging. It's really hard for me to lift my arms that way. And when I don't have the cortisone shots, like lateral lifts, like deltoid lifts, like to the side, I can't do, but once I have the shots, I can do those again. So.
Okay. Have you ever done physical therapy before?
I have.
Okay, cool. So some of this will probably be familiar to you. Anyone else have anything they want to share? All right. Well, we'll go ahead and get started. So I want this class to be interactive. It's hard on Zoom, I know, and it's a little awkward. We're all trying to figure out this technology together for sure. So feel free to interrupt me at any time to ask questions. I also have another therapist here on board who's helping me. So if you have a question but you don't want to ask it, that's perfectly fine. You can type it out in the chat box, and our other therapist can get back to you on there as well, or he can interrupt me and if he thinks it's a good question for everyone to hear. So feel free to do that, interrupt me or type into the chat box here. So I'm actually going to screen share. Let me get my buttons in order here. So I'm going to screen share a PowerPoint here. All right, can everyone see my screen? Okay, I'm gonna pull it up.
So yeah, we can see it.
Okay, I'm gonna pull it up in presentation mode. There we go. Okay, so I already introduced myself. We'll move on from there. Oops. There we go. Okay.
But so, by the way, this is Pam Montanino. So it said to print out this whole thing you're going to show, so you could go along with it, but I couldn't do it. It said it didn't exist.
Oh, that's all right. The attachment. No worries.
Yeah, couldn't do it.
Okay. No worries. We're actually recording this this evening, so we can get you that recording. So don't worry about that. That happens sometimes. Okay. So I'm gonna let's see here. I'm gonna mute everybody, but feel free, that's just to limit the background noise, but feel free, please, at any time to chime in. Okay. So starting with just some really basic shoulder anatomy. If you had anatomy classes, this is not going to be like that, okay? This is going to be very, very simple, just to give our brains a picture of what is really going on here. Okay, so we're gonna start with just the bony structure and the bones and joints and how they kind of move together here. So we have the humerus, which is the arm bone here, and it connects up here into the scapula. So this area here is the scapula or shoulder blade, as a lot of people call it. And that humerus has a ball on the end. So we call that the ball here. And then the part of the scapula that it connects to and inserts into, we call that the socket. So the shoulder we refer to as a ball and socket joint, which is similar to like a baseball fitting into a glove, if you want to think about it that way. The hip is another ball and socket joint as well. Okay, so what that means is it has a lot of mobility because you need to be able to move your shoulder all around during the day. So it's a joint that has a lot of motion versus, let's take the knee, for example. The knee doesn't necessarily need to move in all the directions that the arm needs to move, right? Because we use our hands with daily activities that are different than we use our knees. So just kind of to give you a frame of reference, there's a lot of shoulder problems and dysfunctions that arise because we're able to move it so much. But we need that. We need to be able to use our shoulders and arms throughout the day. Okay, so I talked about that socket there that the humerus kind of sits into. And inside that socket is a labrum. We'll talk about that a little later, but the labrum kind of suction cups that humerus into the socket and kind of holds it tight in place. And there are a lot of other ligaments and structures that do that as well. Okay, so looking here, we also have the clavicle, which is here on the top. And that clavicle connects here into the shoulder blade as well. And then we also have the thoracic spine going down the center here. This is the sternum because this picture is anterior, the front part of the body, but the thoracic spine obviously is behind, posterior. And then we have all of the ribs. So that scapula articulates with all the ribs here. And the reason why the bony anatomy is important is because our muscles connect to the bones in order to move and function. They pull on the bones to get that motion, that mobility. Okay, that's enough of that. Let's go to the next one here. Okay, so we're gonna talk a little bit about muscles. We're gonna talk about muscles in the front and muscles in the back and kind of how we work on those with therapy. So let's just go right into the rotator cuff. That's a big term and a big word that we use a lot. We use it in therapy. We hear it a lot. So does anyone know how many rotator cuff muscles there are other than Raul? Because he obviously can't answer. Anyone want to chime in? My assistant, Brett, is here. You can't see him, but he's over here. He's going to help me with some exercises. Do you know how many rotator cuff muscles there are, Brett? No. There are four rotator cuff muscles. So we're going to talk about those. We often, we say rotator cuff like it's one thing, but there's actually 4 individual muscles acting on the shoulder joint. Okay, so the first one let's talk about is the subscapularis. So that is muscle here. You can kind of see this little red dot where my mouse is here. So this is the subscapularis. It's a rotator cuff that goes in the front across here. We're going to show you what this muscle does in a minute, but it's internal rotation. That means any pulling in. So let's see, if I'm closing a door or I'm closing a closet, I close my closet door like this, right? So that's internal rotation of that subscapularis. The other one in the front muscle is here. It's the supraspinatus. So it's kind of hard to see in this picture, but it's right there on the top. So it comes around here I'm pointing to myself like you can see me, and I'm realizing now that you can't see me. So I'll use my mouse a little more here. So this is the supraspinatus right here. So it comes around the top and connects kind of on the side of the shoulder. So if you have pinpointed pain right on the side of the shoulder, that's often the supraspinatus. And the supraspinatus kind of lifts the arm out to the side. We'll show you that in a minute here. Okay, another one is the serratus anterior. That's a muscle on the front of the shoulder blade. And this isn't a very good picture for that one, so you can't really see it, but it would kind of come right in through here. And then we have the pectoralis major and minor, which cover all these front anterior muscles here. It just goes right across the top. It's a big, broad muscle. And then the bicep, we have 2 tendons for the bicep muscle. Most of us are pretty familiar with the bicep. So there's a long head and a short head. The short head connects right up here to this part. We call that the coracoid process. That's not important though. So anyways, what's important is that you see how close that connection is to the joint of the shoulder. So this dotted line here is that, that ball and socket connection that we were talking about, where the baseball fits into the glove right there. So you can see how close that biceps tendon connects to the joint itself. And then here's the long head. It's coming up this way and around into the very inside of that joint capsule. So the bicep, even though it's not a rotator cuff muscle actually, it's very pivotal to the way that the shoulder acts and functions. And then the deltoid muscle, you have 3 parts to it, but you have one part that goes right over here over the front. You've got one part on the side, and then you've got one part in the back too. Okay, so let's just show you a little bit. I'm gonna stop screen sharing here. There we are. And I'm gonna show you a little bit what those muscles are doing, okay? So first, I'm gonna hold this green band. Brett's gonna help me here. Okay, so he's gonna stand. I'm gonna hold the band. Let's go this way, so you'll face the camera. Let's do your right arm. Okay, so I'm gonna hold the band over here, and Brett's gonna do internal rotation. So this is that subscapularis muscle that we were talking about. So someone who has maybe a small tear or some inflammation in that rotator cuff tendon, this motion is gonna be pretty painful. And so it's not, we'll talk about this later, but when you are having pain with a movement of the shoulder, it's not good to push into that pain. We don't want to activate that inflammation or the tear further. We want to be really careful and cautious with the shoulder, especially. It can be kind of a sensitive joint. The muscles, as you saw, those tendons are really tiny. They're not very small. I mean, not very big. I had one therapist I worked with who used to say that the shoulder is like a bowling ball that's held up in the air by floss. So you can kind of think of it that way. The shoulder is like the bowling ball, and the rotator cuff muscles are like floss. They're not very hefty or strong, not like the quad or the glute, other muscles like that. So we have to be careful with these muscles. When they're inflamed or when they're torn, we don't want to aggravate them further. It can cause a lot more damage. So that's internal rotation. Let me see. I gotta look at my slide here to see what other muscles we talked about. There we go. Okay. Sorry about that. Okay, let's go ahead and do adduction. Okay, I'm gonna show you Brett here. You can do it with the left arm so they can see you a little bit better. So go ahead and turn around and face me. There you go. Yeah, you can do both. Okay, so Brett's doing adduction here. So he's gonna pull the shoulder down to the side. You can turn and face this way, they can see you, yeah. He's gonna pull his shoulder down to the side, and then he's gonna let the weight of the band take his arm up. So we talked about that supraspinatus tendon, right, that comes right across the top and connects here laterally, that other rotator cuff muscle. So that does this. It initiates moving the arm out to the side. Now it doesn't do the full motion, but when you're having pain with reaching out to the side, oftentimes that can be that supraspinatus muscle. So again, we don't want to strengthen that tendon, if it's impaired and inflamed or torn, it's just going to aggravate it further. We want to be really cautious of that. So this exercise is actually working it in a way that's in the pain-free range is what we call it. So he's activating his adductors, which are different muscles, to pull the arm to the side. And then the supraspinatus is working to help raise it with the help of the band. So the band is helping lift the arm. You're not just lifting it on your own. So that can help reduce the pain. And we just work on that slowly over time to build up the muscle that way. Okay, so that's another one. Can you show them scapular punches against the wall? Yep. Okay, so Brett's going to do another one here. This one's a little bit tricky to see. So, yep. So what he's doing, this is called a scapular punch. So this is for the serratus anterior that we were talking about, which is on the front of the shoulder blade. This is a postural muscle here. So what Brett is doing is his thoracic spine, okay, is going towards the wall, and then he's pushing it out against the wall. Okay, his elbows are staying straight. And what he's doing is working on that serratus anterior to build postural strength. Because what happens, which we'll talk about in a minute, is a lot of us with posture end up kind of here all day long, right? So these anterior muscles that we just talked about get really, really tight, and often tight and weak, but very, very tight. And these muscles back here get nice and stretched out, but also very weak. And so what we want to do in therapy is reverse that curve. So we want to stretch the muscles anteriorly in the front and strengthen the muscles posteriorly to keep you in this good position so that you're not here, which causes a lot of pain and impingement, which we'll talk about later, in the front of the shoulder. So that's a great exercise that I do a lot for posture. Okay, that's probably good for this. So let's go back to the PowerPoint and we'll talk about the muscles in the back. Screen share with you here. Okay, so let's talk about the muscles posteriorly now. So we have two more rotator cuff muscles in the back. So we already talked about the front ones, the subscapularis and the supraspinatus. And then in the back, we have two that I kind of tag them together. They do similar things. So with the infraspinatus and the teres minor, which again, these pictures aren't the best. So you can't really see, but they're basically right in through here. They're kind of under these muscles that you're seeing in this picture actually. And those are going to do external rotation, which I'll show you in a minute. That's a really important exercise for posture. If those muscles are weak, it causes your shoulders to continue rolling forward and you're not able to keep that good posture throughout the day. So I'll show you an exercise for those in a minute. Okay, the other muscle that's really important for posture is the rhomboid muscle. So let's see. I've got a few things in my way here. So there we go. Okay, so here's the rhomboid, okay? And the rhomboid connects to that medial or inner side of the shoulder blade, and it's gonna help squeeze your shoulder blades together. So whenever you try and squeeze your blades together, your rhomboids are doing a lot of that work. So we work those muscles a lot for posture as well. The levator scapulae, that lifts the scapula up, that not so much important there. Well, it is, but anyways, not so much for what we're talking about tonight. The upper trapezius is another muscle I want to talk about. Here it is, this giant muscle here. It's big and broad, as you can see, and there's an upper part to it, which goes all the way up to the skull. There's a middle part, which kind of goes out towards the shoulder, and then there's a lower part, which goes down the back. This is a really important muscle. It's a funny muscle too, to be honest. The upper part of the upper trapezius, typically for most people, is really, really strong. If you do a little shoulder shrug right now, you can feel that upper trap muscle kick in. it can cause a lot of problems. It can cause problems at the neck, can cause headaches actually that refer into the forehead, and it can also cause a lot of issues with the shoulder. Because that muscle is so strong, it tends to take over when the rotator cuff muscles are weak. And so it's going to overactivate and cause some problems with the way that the shoulder moves. And so we definitely have to address that in therapy. The latissimus muscle, you can't see it here because my picture is cut off, but it goes all the way down kind of the back on both sides. So that's an important muscle too. Activating that as well as the lower trapezius helps kind of counteract that upper trapezius that's so overactive in most people. All right, so let's go ahead and show you some of those. So I'm gonna stop this screen share. We'll go back here. Okay, so Brett's gonna show you a really basic exercise called shoulder extension with the band here. So he'll face the door. All right. So this is for, there are a bunch of muscles that are working with this exercise, but specifically the latissimus muscle that we talked about that goes all the way down the back. That's one muscle we're working on here. The rhomboid muscles that are squeezing the shoulder blades together are also working as he pulls down. Let me turn the camera a little bit for you. As he pulls down, he's squeezing his shoulder blades together. So his shoulder blades are going down and together as he pulls that band back. All right, so this is a great exercise for posture as well. Okay, let's show external rotation with the green band with both arms. You can face the camera for this one. Okay, so Brett's gonna show you external rotation. So we were talking about that infraspinatus and teres minor, those two rotator cuff muscles in the back. This is a great exercise for those. So this, similar to the shoulder extension, is going to get you out of that forward hunched posture that most of us are in all day long. Okay, so he's working that external rotation here. This exercise fatigues you pretty fast. I think we should leave Brett here and see how long he can do it before he has to quit. This exercise, it's tough. So a lot of the scapular shoulder exercises we're doing are not just for strength, but also for endurance, because you need those postural muscles all day long as you're sitting, right? So that you don't go forward hunched like this, okay? Let's do over the ball. I'm gonna show you another postural exercise that I like to do a lot. These ones are called YTIs, and that's just in reference to the position of the arms. I'll have you go sideways. So I'm going to move the camera so that you can see Brett here. Okay, so Brett's going to start with the eyes. So palms are facing up towards the ceiling. What he's doing, go ahead and bring your arms towards the ground. He's going to squeeze his shoulder blades together and then lift the arms up. So that's how we get really good activation of those postural muscles. The other thing is he wants to look straight towards the ground so that he doesn't extend at the neck and cause issues there as well. Okay, so that's the eye. Let's do the T's. So straight out to the side. Same thing, he's going to squeeze his shoulder blades first and then lift the arms. And notice how his back is nice and flat. So doing an exercise like this on the ball forces you to use your abdominals as well to keep your spine nice and flat and to keep yourself from rolling off the ball. So when we do exercise in the clinic, we're working a lot of different muscles and muscle groups, especially with the shoulder. We have to work the abdominal muscles in order to keep that good posture. All right, and let's do the Y's. So coming up into a Y, his thumbs will be pointed up towards the ceiling. And he's going to squeeze his shoulder blades down and back. Perfect, just like that. These exercises are really hard. They fatigue you pretty fast, but they're great for postural strengthening as well. All right, thanks, Brett. I'm gonna move the camera up here a little bit. All right. Okay, where I'm gonna go back to, you know what, let's show a row. Sorry, Brett. All right, one more. It's okay, you can do a high row up there. Okay, Brett's gonna show you a row here. All right, so he's gonna squeeze his shoulder blades. Let me turn the camera for you. Squeeze his shoulder blades and pull his elbows back to his side. So that's another one that works that rhomboid muscle that we were talking about that brings those shoulder blades together. And that's gonna help a lot with posture. So with all these exercises, his abdominals are also engaged. Okay, so we're working a lot of different things here. Very nice. Thank you, Brett. Okay, let's go back to our PowerPoint. I'm gonna screen share here. Before I do that, does anyone have any questions for me at this point about exercise or how the muscles work and function? Okay. I'm gonna go back to the screen share then. Okay, so let's talk about how the shoulder moves. We have a big word for this. We call this scapulohumeral rhythm. That doesn't really matter for you, but what you need to know is that how the arm and the scapula move together is what raises the arm above the head. That's why we do so many things with the scapular muscles, because those muscles are really important for arm elevation. Okay, so I'm gonna show you a video here. I hope, let's see. Here we go. Okay, so this video is just going to show you how a shoulder moves. Now this is a normal, this is just bony anatomy here. It's a skeleton that I'll show you. And this is how normal shoulder movement occurs without any dysfunction, okay? That's it right there. Okay, so we're gonna slow it down a little bit here. All right, so this is the scapula we were talking about. Okay, this is the ball here that's sitting in the socket of the humerus, okay? So what happens when that arm raises high above is that this scapula has to rotate this direction, okay? It has to come down and out. And then also I want you to watch the ball here as the arm raises and watch how that ball rotates. Okay, I'm gonna show you this video again. Here we go, so that scapula moves down and out, and now let's watch that ball. Do you see how much movement that ball has in the socket? We're gonna watch it again. Brett wants to watch it again. Okay, so that ball is moving down first, okay? It has to move downwards in that cavity a little bit, and then it's rotating. It's rotating a couple different directions. It's rotating this direction. Let's see, what is that? Counterclockwise? Yes, okay. Yeah, it's rotating down, counterclockwise, and then it's also externally rotating. What that means is if you take your arm, let's just take the right arm here, okay? And if you move your thumb from forward facing towards your computer, okay, and you move it back behind you towards your spine, okay, that's external rotation. So it's like you're flipping the palm over like a pancake. Flipping a pancake is probably a better way to describe it, okay? So if you're flipping a pancake, that's external rotation. So that's also occurring at the shoulder in order to get that arm up overhead, okay? So when that scapula isn't moving like it's supposed to, when it's not moving down and out, you have a lot of issues. It's hard to get that arm up in the air. When that ball is not rotating down and counterclockwise and not externally rotating, you have a lot of problems. See this area here on top of the ball and socket between that part of the scapula? There's some structures in there that can get pinched. We call that impingement. And that occurs when that ball isn't moving correctly in the socket. It's not doing the motions that it needs to do. And so what happens is it pinches those structures at the top when you try to lift your arms. And as you do that over and over and over and over again, because we lift our arms all day long, right? That's when you have a lot of inflammation that can occur and even some tearing. Okay, so I just wanted to show you that video a little more exciting than my PowerPoint. Okay, well, let's go back here. Maybe. Okay, sorry here, let me get back to my PowerPoint. There we go. Phew, okay, I got it. All right, I'm gonna screen share with you here again. Okay, so moving right along, let's talk about posture. So this lady here, you can see sitting in the chair, she's having the red lightning bolts, I believe symbolizes pain, okay? So she's having pain in her thoracic spine, she's having pain in her low back, and she's probably having pain in her shoulders too. But this is the posture that most of us find ourselves in during the day, right? We're not really thinking about it. This is just kind of our go-to. But poor posture can lead to impingement, that pinching at the top of the joint space like we were talking about. Impingement and pain. It causes the anterior muscles to be tight. It causes the posterior muscles in the back that we were talking about to be really weak. And it also prevents full shoulder motion. So I'll demonstrate that in a little bit for you. But when you're sitting like this, well, let's just go ahead and do it. We'll just go ahead and do it. Okay, so I want everybody to sit kind of forward slumped like this. Okay, just like this. And then try and lift your arms up. Okay, so this is as far as I can go. You might be able to go a little further than me. Okay, but that's about as far as I can go. So when I'm here, what is this? Can everyone hear me okay? I got a notification that my speaker wasn't.
Yeah, we can hear you.
Okay. Okay, perfect. Thank you. Just wanted to check on that. Okay, so when you're here and you try and lift the arms, it doesn't really work, right? But if you sit up nice and tall, then you can lift the arms all the way up overhead, no problem. So that's why we work on posture so much. Really, it's just as simple as that. Okay, so let's go ahead and talk about common shoulder problems that we see often. So these are a list of some different things. We've touched on most of them already. Impingement, rotator cuff tears. You can have tendinitis, which is just inflammation in the tendons of the muscles connecting into the bones. Arthritis, which is just joint pain. We'll talk a little bit about that. And also instability, which is a shoulder. I mentioned that the shoulder moves a lot for a good reason. We need our arms to move a lot. But you can have an unstable shoulder where that joint is so mobile that it can cause pain and other issues as well. So the question is, how do we really know the difference when you come in for an evaluation and we look at your shoulder? How do we know really what's going on? Okay, so there's some different special tests that I do when I'm treating a new patient to figure out what's happening. So if you haven't had an x-ray or an MRI or anything like that, that's perfectly fine. And honestly, I do the same tests usually even if you do have imaging. So let me show you some special tests here. Okay, so Brett's gonna be my patient. Why don't you just sit on the stool here, Brett, for me? Probably better than the ball. Okay, so Brett comes in with shoulder pain. He's not really sure what's going on. He hasn't been to the doctor yet, so he doesn't have a referral. He came straight here, and he wants me to figure out what's happening. Okay, so the first question I ask him is, how long has this been happening?
A couple of years.
Couple of years. Okay, so that tells me that this is a chronic issue versus acute. So if it's been happening maybe a few weeks or maybe even a month, I would consider that fairly acute, which means there's probably a lot of inflammation. And if we can get that down, we can probably correct it fairly quickly. A chronic problem, just a little bit longer, if it's a couple years, is probably chronic. That's a little bit more tricky. That means that there's some problems there in the shoulder that have been happening for so long that it's caused chronic pain. Okay, so I'm just going to go forward with what I would do kind of an initial examination is I would have him sit up nice and tall with his feet flat on the floor and go ahead and lift both arms straight overhead. Good. Now, Brett doesn't have shoulder problems, so he's obviously going to be able to do all of these things. But normally, someone might not be able to get all the way straight overhead. Okay, I'll have you bring your arms down and then go from the side all the way straight overhead. So oftentimes, that motion is a little more aggravating. Okay, you can come back down. Good. So now I see he has full motion, so I'll ask him, where is your pain at? Right over there. Okay. So where the pain is at kind of tells me what's going on too. So those muscles and where they attach, like we were talking about, gives me a clue. So if he's having pain right over here on the outside, then that's often the supraspinatus. Okay. If he's having pain more back here, posterior shoulder, then I'm thinking more infraspinatus teres minor. He's having pain in the front, it could be subscapularis, that internal rotator. It could also be the biceps tendon that connects right there in the front too. I can kind of roll over that biceps tendon, even though we talked about the end of the tendon really goes into the joint, but I can kind of roll over that tendon a little bit here too. Okay, so some different things just to check. For impingement, that's the pinching at that top of the joint here. So one test I do for that is called Hawkins-Kennedy. You don't really need to know the names, but I just wanted to show you what I do, okay? So I'm gonna come here, is that painful? Okay, and just kind of rotate him around. So someone with impingement is gonna feel it, the closer here inwards that I get, they're gonna feel that usually right at the top. And they usually too have some pain as they lift the arm, kind of in this 60 degrees to 120 degree range. That's when that shoulder joint really needs to rotate, that ball that we were talking about. And so if it's not doing that rotation, he's going to get a lot of pain at the top of that joint. So I see that pretty commonly too. For the supraspinatus, okay, one thing I'd have him do is just kind of lift the arm out to the side and back down and just kind of fling it. So if he has pain there and he points here, that's what I'm thinking, probably supraspinatus. The other thing I can have him do is hold the arm out here, okay? And then sometimes I even resist it, so hold that there and I push down. Okay, so the degree of tear that's going on in that tendon, if there is a tear, I can kind of tell based on my test. So if I can do a muscle test and it's pretty strong, but it's painful, then it's probably only a small tear. But if that muscle, if he comes up here and I push and he just falls down, then that's a little bit more involved. And even further, if he can't get his arm out here and hold it at all against gravity, then that's pretty significantly involved. Okay, so that's another one. So I'm gonna have him come here with thumbs up, right? He's gonna bring his arms out this way to the side and he's just gonna hold it. So this is for that external rotation, infraspinatus teres minor in the back. So if those muscles are weak or there might be a slight tears or inflammation, something going on there, his arms are gonna kind of come in this way naturally. And it may only be one. One arm may drift towards his stomach and the other one may stay out. Okay, so that's something I look for. You can relax your arms. Another test I do, there are so many, I'm not gonna go through all of them, obviously. That you'd be here all night. But this is another one. Okay, so he's gonna hold his arm here. This is the bear hug test. Yeah, just one arm. So that's for that subscapularis, that rotator cuff in the front. So he's gonna hold his arm here. And what I'm gonna do is try and lift his arm off his shoulder and he's gonna hold it. Good, so that's nice and strong. So all of these tests are basically, I wanna know, are you having pain when I do this? And then I also wanna know how strong you are. Can I give you any resistance? Do you give against gravity? Can you hold it up against gravity? All of those things I'm looking at to try and figure out what's going on. So that's just kind of a little bit of insight of what we do when you come into the clinic, especially if you haven't had any imaging. I'm gonna sit on the ball. Thank you, Brett. All right, let's go back to my PowerPoint here. Oops. Okay. So just quickly, we've already talked about a lot of these, so I'm not going to go into much detail with them, but impingement is that pinching at the top of the joint when you go to lift the arm, which can be caused, like we talked about, when the scapula isn't moving correctly, when the ball in the socket is not rotating like it should be. So that's often caused by poor posture, poor movement of the scapula, weak rotator cuff muscles, weak postural muscles, and that overactivated upper trap, this upper trap right here that we also talked about earlier. So lots of things going on with impingement. That's a really common thing that we see, and it can be paired with other things. You could have a rotator cuff tear and impingement. Unfortunately, a lot of things kind of go hand in hand. Okay, so the rotator cuff, we've already talked a lot about this. So that there's 4 rotator cuffs. You can have a tear in one of them. You can have a tear in all 4 of them. The bicep tendon is not one of them, but oftentimes if you, people who have a rotator cuff tear, we see tears in that biceps tendon as well. And people who've had surgery, a lot of them have that biceps tendon repaired along with some of the rotator cuff muscles too. A lot of people want to know, okay, if I do have a tear, can it heal? You know, what's physical therapy really going to do for me? And the answer is it can heal depending on the severity of that tear. So if it's a partial tear, meaning the tear isn't through the entire tendon, only part of it, then it can potentially heal. Some of the rotator cuff tendons have better blood flow than others, so some of them are more likely to heal than others. But we can also do some things in the clinic to facilitate that blood flow, which is going to help with healing. A full thickness tear cannot heal without surgical intervention. So if you have a complete rotator cuff tear, that tendon will not heal. However, that does not mean you have to have surgery. Surgery for the shoulder is elective. It's your choice, and it depends on what your function is. If you can function during the day with your shoulder how it is, maybe you're having pain, but it's not that bad, you want to deal with it, you don't want to do surgery, that's perfectly fine. We can work around that specific tendon that is fully torn. You have other muscles that can do similar functions. We can still strengthen, we can still work on posture and do a lot for you, help reduce your pain levels, even if you don't want to have surgery. Okay, that's my soapbox. Moving on, tendinitis is just inflammation of the tendon that connects that tendon connects the muscle into the bone. So that's usually a temporary thing. It can develop more chronically, but typically it's temporary and we can treat that pretty easily. Arthritis is joint pain that it causes the bony structure itself. It can lead to swelling and decreased mobility. Arthritis is part of the aging process, unfortunately. But it is more common among those who have a history of stress to the shoulder joint. So if you have a history of shoulder dysfunction, if you've had shoulder surgeries, or say you were a weightlifting athlete, or you've just put a lot of stress on that shoulder, that arthritis, that arthritis will kind of speed up a little bit. Okay. Instability. We didn't talk about this too much. But just to touch on it quickly, a shoulder that has too much mobility can lead to impingement, that pinching. It can also dislocate. We see this most commonly, at least I feel like I see this most commonly with younger kids who don't have that muscle stability and strength in their joints yet. So I see in unstable shoulders in kids. Throwing athletes like baseball players, they need a lot of mobility, right, in their shoulder in order to play. But if they have too much mobility, it can cause dislocations. So the one thing we didn't touch too much on is the labrum. I mentioned it at the beginning. That's just where the ball is kind of suction cupped into the socket. The labrum kind of holds it close and tight, like the glove. Imagine an inner lining on a baseball glove that's suctioning that baseball tight in there, or Velcro or something like that. You can kind of picture. So that labrum is really important. And oftentimes with rotator cuff tears or a bicep tear, lots of things going on in the shoulder, you can also have a tear in the labrum. We call that a slap tear. And that you don't really need to know too much about that. But basically, when we see that, there's often instability in the shoulder joint as well. Okay. Okay, so the big question tonight is, why do physical therapy, right? I get a lot of questions from patients and from potential patients about, is physical therapy really worth it? Because it is hard work. You know, we ask our patients to be here 2 to 3 times a week for multiple weeks, sometimes 2 to 3 months, especially after like a surgical procedure. You know, it is hard work. To really strengthen those muscles. And so we have to ask ourselves, is it worth it? Is it worth doing this? And can it really help me and my pain? I already answered the question, do I have to have surgery? So we'll skip that one. And then the other common question is, can I just do the exercises at home? A lot of people want to know, can they just Google some exercises and do them on their own at home? Well, the problem with that, like I showed you with our exercises today, is that we're really targeting very specific muscles. I want very specific muscles to activate and to work for you the way that they're supposed to. And when you do exercises at home that you've never really done before and aren't instructed in them, then it's difficult for you to know if you're really activating those muscles. In addition, a lot of people with shoulder pain and dysfunction that have poor postural mechanics don't know how to activate those muscles. Your brain has kind of turned that off. And so I have to do some things in the clinic to really get those muscles firing before I can even get you exercising. So it's really important that you are here in person, being able to do the exercises, being able to make sure that your muscles are acting the way that they're supposed to before you eventually are on your own doing exercises at home. So when you come in, we do give homework, right, that you're going to do at home, but I want you to know how to do those exercises and what muscles we're working on, and to really know what you're doing before you just go home and start doing them. Okay, and the other big question is, I think this is on my next slide. Hold on, I gotta find my other slide. Here it is. I skipped this one and it's my favorite slide. Okay, so the big question is, won't my pain just go away on its own? Right, so I love this slide. I told you earlier I have a little 1-year-old at home and he loves to play peekaboo, right? Like these kids do. And so he thinks that if he covers his eyes and closes them, that I can't see him, right? And when he opens his eyes, there we go, I can see him. And that's how it is when we ignore our pain, to be honest. Even though maybe this week your pain is better than last week, maybe this month your pain is better than last month, or even this year, better than last year. The problem is that the mechanics of how the shoulder is moving and functioning are not changed. And so even though pain can kind of wax and wane, it can get better, it can get worse, depending on your activities, the cause and root of the issue is always going to be there unless you work on the strength and the mechanics of your shoulder. Okay, coming back here. Okay, so what is the next step? I'm going to stop screen sharing so you can see my face here. Okay, so the next step is to sign up for an evaluation or a free screen that we do here in the clinic. So an evaluation is going to be kind of like what I showed you with Brett, where he comes in, I do some tests, I look at the shoulder, look at your mobility, I see what's going on. And that really in-person evaluation gives me an idea of what's happening at your shoulder and how we can address it with physical therapy. So that's really a key component. You don't need a physician referral to come in just for an evaluation. Usually later down the road, we do ask for one, but initially you can come in. The other option, if you're still unsure about whether or not PT is right for you, or you're unsure about insurance and how it's going to work and all of that, you can come in for a free screen. And we'll do that quick 10, 15 minutes. We'll just kind of screen your shoulder, tell you what we think is going on and how we would progress to treating that. But we wouldn't do any treatment or give any exercise or anything like that for the free screen. Okay, so does anyone at this point have questions for me? Okay, let me just pull up lastly here my email. Okay, so this is our address for our West Hills office. We also have one in West LA. if that location is better for you. But this is our address for West Hills, where I'm located, and this is our clinic phone number. So you can give us a call and let us know if you're interested in an evaluation or a free screen. And then this, in addition, is my email at the bottom. So if you have any questions at all about what we talked about today, or about physical therapy in general, feel free to email me and I will be happy to get back with you. All right. Thank you guys so much for hanging out with me tonight.